I'm Barbara Norman. I'm the Chair of Urban and Regional Planning here at the University of Canberra and also Director of CURF. For those who are new tonight, welcome, and you're joining a really great collegiate and following that's developing around CURF. CURF has a theme in it called Health and Wellbeing, which has been led by Professor Tony Capon, who's right in the front here, was here and now Director of the Health and Global Health Unit in the United Nations University in KL. So we now have gone international with CURF, and so that's an exciting step for us. I should have started right at the beginning, as we always do. My apologies. I'd like to acknowledge the Indigenous people, both past and present, and thank them for allowing us to have this event here on their land tonight. CURF itself seems to be going from strength to strength. We've got finally signed the contracts with the ACT government on the $500,000 grant, so we can actually take that a step forward. And we've just put in an ARC, Australian Research Council, for those who don't work in universities. It's our national research body, a linkage grant on extending our coastal adaptation work. With the federal government, Department of Environment, contributing $80,000 towards that, and a number of other partners with local government. So I just mentioned a couple of those positive steps forward to say that we're going from strength to strength here and developing quite a good team and good relationships with local councils in our region, as well as the ACT government and the federal government. However, tonight, that's enough of CURF really, the background. Tonight we have a great pleasure, I have great pleasure in introducing our final speaker, not for CURF, this is going to go on forever, for many years to come, but for our Centenary Series this year, which has been really an excellent set of speakers. Tonight we have the really important topic of healthy cities, which is attracting more and more international attention. And the ACT government itself is particularly interested in this, with the Minister and also the Chief Minister is as well. University researchers are beginning to join the dots, and that's where Tony Capon has shown great leadership here at this university. Tony, I should say, has stayed as an adjunct professor with us, so continues that relationship. So tonight we have Andrew Dannenberg from the University of Washington. I won't go through all his CV. He is our Fulbright Scholar. He's our first CURF Fulbright Scholar, and is well known for his leadership in collaborative efforts to address the health challenges of urban environments. Collaboration being very much the key theme of CURF and fits really well with Andy's agenda. He works with the School of Public Health at the University of Washington in the States, a recognised centre of excellence in the field of healthy, sustainable places. I've had the pleasure of having Andy around here for 1 week already, and I know that he has got a lot of very interesting things to share with you tonight. So please welcome Andy to the stage, and we look forward to your presentation. Thank you.
Thank you. Thank you, and good evening. It's a privilege to be here. I'd like to start. We're talking about the built environment, and we have choices of what our built environment looks like, and those various choices do affect health. I'd like to start by reading a story. The citizens of Bay City were fed up. Getting across town to go to work or shopping had become an ordeal. The streets seemed perpetually clogged. It was impossible to find parking. For people who had bought homes in the suburbs, life seemed like to take place more and more in their cars. Chauffeuring children to school and soccer games, driving long distances to stores, and worst of all, commuting to work. Meanwhile, the local newspaper reported bad news on air quality, on increasing obesity, on everyday car crashes. The mayor, the city council, and the transportation department teamed up to address some of the quality of life issues. They envisioned an ambitious program of road building. Key components were a 6-lane arterial highway along the bay shore, 2 new arterials crossing the city, thousands of new parking spaces. Although this plan would destroy historic and beautiful bay views, sever old neighborhoods, remove half of a city park, it would move the traffic more efficiently. But the roads were never built. The local health department, urban planners, architects, physicians, nurses, park officials, historic preservationists, environmentalists and neighborhood associations all came together in a remarkable display of unity. The coalition they formed proposed an alternative plan. One that's centered on extensive pedestrian and bicycle infrastructure, investments in bus and light rail transit, mixed-use development along the Bayshore, and investment in parks throughout the city. It emphasized equity, included policies to avoid displacing established communities, and to ensure a mix of housing types. The cost of the alternative plan was slightly less than all the combined roads that the Transportation Department wanted to build, and it would actually generate a similar number of construction jobs. Fortunately, the alternative plan won the day. It took more than 20 years to implement, and it required considerable political leadership to stick with it during the inevitable cost overruns and budget crises. But after 20 years, there was a remarkable series of changes in that community. The proportion of people walking and biking had gone up substantially. The students walking to school had gone up a lot. Transit ridership was way up. Traffic volume was actually down some. Air quality was a little bit better, and obesity seemed to be stabilizing. Because many young families had moved into the city, the public schools had improved considerably, were now among the best in the state. And Bay City had become a destination city, attracting several prized high-tech and biotech firms because of its well-recognized commitment to environmental sustainability, health, and the quality of life. That's to give an image of what choices we make longer term do make a difference. And the built environment is a big part of what we want our cities to look like longer term. One thing you may notice from that is who was at the table. The initial plan for lots of roads was the mayor, the city council, and the transportation department. All those other residents were not really being represented there. But once a coalition got together that represents the broader range of interests in a community, a much better plan can come up that will impact health in the longer term. Okay, very briefly, what is health? State of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. It has to do with livability, that larger picture of not just treating illness, but giving people a livable place to live. What affects health? I'm a physician coming from the health world. What we are trained in tends to be toward the top of this pyramid. We educate patients, eat a healthy diet, get some exercise. We do some treatments here, have a drug to treat your illness, or give a vaccine that may have a longer impact. But what really changes people's health in the long term and on the larger scale is if we change the context in which people make decisions, and that has to do with a healthy built environment. Here's really the summary of the whole talk. I'll be back to talk about each of these items, but the big areas where community design affects health relate to land use, automobile dependency, and social processes. Under land use, the big issues: obesity, physical activity, cardiovascular disease, and that's the one that most people think of. Oh, a healthy built environment means a place people can walk. But it also affects water, quality and quantity, access to healthy food. Automobile dependency, effects on air pollution, asthma, climate change, car crashes, pedestrian injuries, and mental health and social capital, environmental justice issues related to social processes. So to talk for a minute about physical activity, as I say, that's the one people understand the most. Why does it matter? It makes a big difference in health. A sedentary lifestyle increases the risk of overall mortality, heart disease, and certain types of cancer. And inactivity is similar as a risk factor to high blood pressure, cholesterol, diabetes, even smoking. What determines physical activity? If it's easy and convenient, people are active. If it's difficult, if they're tired, if they're not motivated, they're spending all the time in cars, it's not likely to happen. Obesity has similar outcomes as physical inactivity: overall mortality, heart disease mortality, gallbladder disease, diabetes, hypertension, very much overlapping what you're seeing at airplanes, where as the US gained an average of 10 pounds, if you do a simple multiplication of that extra 10 pounds over 10 years and how many miles people are flying and the extra fuel needed to fly that extra 10 pounds times many miles, it adds up to a very large number of extra gallons of fuel with climate change implications just from that. Again, something unintended costs of obesity, but there's many outcomes from obesity. In the US, watching the obesity epidemic went from 1995 to 2010, where in 1995, basically all of the states were between 10 and 20% obese. By 2010, it was all over 20% and some over 30%. In Australia, similar numbers, the proportion obese for males and females from 1995 to 2011, going from roughly 18% to 28%, with similar numbers for both males and females. How do we design to encourage physical activity? A simple schematic here of a community. A lot of suburban developments separate out the schools and the houses and the apartments and the malls, and the roads don't permit any connectivity. A more traditional design is more of a grid-like network where it's possible to walk from one destination to another. So here is a suburban community from the air, not uncommon, flying into many cities. You can have two kids who live 100 meters from each other and find they can't walk to each other's houses because of that failure of connectivity. And then we get strange policies. Here's a policy that says we'll put a wheelchair ramp at every corner, and another policy that says every property owner should put a segment of sidewalk in front of their property, and no planning that says maybe the two should be connected. These are not uncommon. We have lots of pictures like this. We get transportation designs that don't make a lot of sense. It doesn't really matter if that sidewalk came first or if that pole came first. That's not design. It's a failure of design that should even exist. Similarly, that cloverleaf is a great way to move motor vehicles, but is a total failure for public transit, for walking, for biking, for preserving green space that's usable. On the other hand, we have some success stories. This is a bridge in Charleston, South Carolina. The old bridge is in the background before they tore it down. The new one in the foreground, spectacular setting. Big fight over, should we give a walking and biking trail along that bridge when we build the new one? And in the end, the good guys won. They were able to build the walking and biking path. Originally, they said no one would use it. They're now fighting over how much parking to build at the ends of the bridge because it's become a destination where people are driving distances just for the privilege of walking and biking on the spectacular bridge. Parks, very central to sites for physical activity. Some are built very poorly in terms of access. This one in Atlanta on the left can only be driven to as compared to the one on the right where there's the option to walk right out your house into the park. One of the issues is we are not trying to dictate behavior. So in providing a park, we are providing an opportunity for people to choose their physical activity. And some people will make other choices. In this case, it turns out the woman driving the car has a show dog that needed substantially more activity than she could give it. So this was a choice she had made to exercise her show dog. We also get proposals like this. This is coming from Atlanta, where I worked at Centers for Disease Control for 15 years. And the planners say, gee, we have traffic congestion, what can we do about it? Why don't we just take that 16 or 18 lane highway and make it 23 lanes? That'll certainly take care of the problem. And sort of no awareness that the failure of the public transit in that city might be a better choice to improve public transit than make proposals like 23 lanes that will fill up within a few years of building them. We know that other countries have done better than the US on walking and biking, and if you look at a number of European countries such as Germany and Netherlands, much higher rates of proportion of their trips by walking and biking, and lower injury rates because they've built the appropriate infrastructure. We know in the US that we do have examples of where they've done the right thing. So in Portland, which is often one of our examples of doing it right, they put serious investment into bikeways, and over about 15 years quadrupled the number of miles of bikeways and found a quadrupling of the number of people using those bikeways at the bridges that are central to the city where they were doing counts. There was also a study looking at the cost-benefit analysis of that long-term investment in Portland by Thomas Gotchi, who looked at what it would cost to do the full planned bikeway infrastructure in Portland and found major savings in healthcare costs because people are healthier if they can walk and bike, as well as fuel savings, and got very favorable cost-benefit ratios on the long-term investment that was underway in Portland. We've had some good news recently. There seems to be, after many years of increasing vehicle miles traveled and vehicle miles per person that were being done, that it seems to be leveling off and possibly even falling. And that's a whole range of societal changes. Everything from the recession may have contributed, the price of fuel rising, but also possibly the younger generation recognizing, hey, there are some alternatives to transportation, and we're actually seeing teenagers starting to delay when they get their first driver's license. It used to be they always got at the earliest age they were eligible, and now they're starting to delay it some. So this is a sign in the right direction, and we'll see how it translates to other countries and what it does over the next few years. Again, a behavioral choice, how you build it. People have the choices. There's a saying, make the healthy choice the easy choice. And if you put the stairs in front of people and put that escalator around the side somewhere, you'll be able to predict more what choice people will make. One of the areas where some work has been done in the States, in part because the Transportation Department had put some money into it, was trying to make it safer for kids to walk to school. We found that the biggest barriers to walking to school was the distance to school and the traffic dangers. Both of those are built environment issues. The distance to school depends on where those schools are. And while schools don't change frequently, there are still new schools being built, there are schools being redeveloped, and those choices get made. Do we build a big school way out that everybody drives to, or do we rehabilitate the smaller school that's closer in so kids can walk to it? Traffic danger is something any traffic engineer knows how to fix if the political will is there. There is some evidence that children will gain habits as children that will carry them through a lifetime. If a child has only been in a car as the only way to get from point A to point B, that's how they will think is the normal way to travel. If they've learned walking and biking as normal transportation as children, there's at least some evidence that will help with their future habits on physical activity. We get a school like this, outstanding in its field. I'm sure the land was inexpensive. The number of children who will walk and bike to that school is very close to the number 0. We also found by looking at where schools are located in more urban areas that tend to be closer, and if there's money for fixing the areas around schools, you end up in the more urban areas actually helping most of the community. So that by putting some of the focus on getting money for safe routes to school, it's actually a good foot in the door for improving overall communities for walking and biking. In the more rural areas, obviously, the schools are further apart, so that doesn't work as well. Moving on to air pollution and asthma, we had a natural experiment during the Summer Olympics in Atlanta in 1996. Traffic is always gridlocked in Atlanta. The population was told that during the Olympics, the traffic will only get worse. Nothing's going to move at all. And people actually heeded the warnings and cut back on their traffic. And so during the 3 weeks of the Olympics, peak morning traffic went down 23%, ozone levels went down 28%, and asthma-related emergency room visits for kids went down 42%. When the Olympics were over, traffic went back up, the bad air went back up, the asthma visits went right back up. Natural experiments like this give us evidence that if you try to fix things, it really can make a difference. Water, another major issue affected by built environment, particularly water runoff, pollution of streams, siltation, environmental costs, economic costs, all related to built environment. Injuries, leading cause of death among young people. 34,000 deaths a year in the US from motor vehicle injuries. Millions in non-fatal costs, billions in overall costs. The road you see there is Buford Highway, which is actually outside of one of the CDC facilities. A 7-lane highway, no pedestrian medians, traffic lights a mile or more apart, and one of the highest pedestrian death rates in the nation based on poor design. Mental health issues affected by community design. Depression can be both prevented by physical activity and treated by physical activity. Stress can be aggravated by long commutes, sitting in traffic. Attention deficit hyperactivity disorder, greenspace may actually help it. And we see a certain amount of road rage in some of the more stressful road situations. Social capital, defined as civic engagement, social networking, trust, and reciprocity. It's your interactions with your community. People who spend long time in their cars commuting have less time for their interactions with their communities. And things that build social capital. If you build places that people want to be, they interact with each other. This was a small experiment in one of the intersections in Portland, where they're drawing a large sunflower made it a place people wanted to go to, and they actually looked and found people stopped, and they talked to each other, and they read the signs, and they took photos. There's also a whole range of equity questions that arise related to how we build our environments. And we would like to think that something like this is a cartoon where we put the really rich people in one place and the middle class in another and the working class a third direction. But in fact, it's exactly what we do. If you go out to many of the suburbs in the States, you'll see these ads that tell you if you can afford such and such a type of home, you go this direction. If you can afford a fancier home, go that direction, because it's going to separate you by your income, which is not healthy for society. Here's one that was fairly shocking. This is the city of Baltimore, which is actually where I grew up, where within 5 miles of each other, there are 2 parts of the city that have a 20-year difference in life expectancy. In Roland Park, in the northern part of the city, everything you would expect in a well-off area. The resources are there, the education is there, the transportation is there, the good housing is there, the jobs are there, everything that people need is available. In Holland's Market, in the inner city slums, all of the things that lead to a healthy life are missing, and only 5 miles apart, a 20-year difference in life expectancy. Climate change issues, you hear a lot about that, all very compatible with the issues that lead to healthy community design. Transportation alternatives, density, land use, parks, green space, energy efficient buildings, all these can be used to help mitigate climate change, but also contribute to a healthy built environment. One of the approaches that has a lot of attention in the developing world is called smart growth, and many of you may have heard of the term. It has to do with designing with higher density, more contiguous development, preserving green space, mixed land uses, walkable neighborhoods, having roads but balancing the transportation alternatives, having architectural, economic, racial heterogeneity, development and capital investment balance between the central city and the periphery. To do all of these needs regional planning. If all planning is done on a very local level, it fails to see what the larger community needs. Smart growth gets a bit political, and some of the issues that come up, it's not against roads and cars. Smart growth is looking for more balances and more transportation choices. It's not against suburbs, it's having vibrant cities and suburbs and towns. It's having wider housing choices, not trying to tell people where to live. And it's certainly not against growth, it's advocating for planned growth. So just as an example of the kinds of changes, here's a road, if you saw, you would probably just as soon pass through. There's nothing much there that would grab your attention or a reason to want to be there. But if you started adding some greenery and some trees and some transit and people on the street and some shops and some places to live, it starts to become a place that people may want to be. Various policies can promote walkable communities. One of them is called complete streets, which are streets designed so not just for cars, but are designed to accommodate all legitimate users. So they accommodate the bicycles, the pedestrians, the transit, as well as the cars. There's also a system called LEED for neighborhood development. Some of you may have heard of LEED for energy efficient buildings, which is a system that's been around probably 15, 20 years to encourage architects to build buildings that are energy efficient. That has now expanded to the whole neighborhood level, looking at, it includes the energy efficient components, but also looking at more of the green buildings and walkable communities and transit and green space, and having the overall development of the community be more health promoting. And this is starting to catch on. A community can become LEED ND certified, which then is actually useful as a marketing tool. And one of the issues in healthy community design is to work with the market, not against it. So if something such as a certification saying we are a health promoting green community helps sell the buildings there, that helps the developer and everyone benefits. There are also some tools, and those of you who may not have seen this, I encourage you to try it. It's walkscore.com. It is available in Australia and the US and a number of other countries. And it basically, you can put in any street address and it will give you a walkability score of 1 to 100 based on what is nearby that particular address that you put in. It's got a lot of use, has been used in a number of research projects, but one of the ones that can start to influence the population is it's now starting to appear in real estate listings. So when I want to buy a house with 3 bedrooms and 2 bathrooms, I can also put in and say, I want a walkability of at least a certain level. And after a while, as it becomes more prominent, then people will start making their market choices and choosing where they want to live. That the walkability, by having this score in there, can start to influence what people want and what the builders want to build. The builders want to build what people are asking for. There's also other programs that are starting to catch on around the world. Bike share programs encourage biking, particularly for short distances. And it's caught on a number of places in the US and Paris and elsewhere. One of the concerns has been on helmet and helmet use, especially in places such as here where there are helmet laws. I just took this picture in New Zealand a couple of weeks ago where Auckland now is starting to put a helmet and attaching it to the bike on the bike share program. And I think from having spent the past week doing some cycling in Canberra, you have an absolutely fantastic infrastructure for biking with trails all over, bike lanes, and I would encourage the decision makers here to consider finding a way to work out the helmet issue and get bike share, because it really is a superb way for the shorter distances around town, especially once the infrastructure is here. Architects are also a big part of built environment. When we started working on built environment issues, we primarily focused on the urban planners who look at the larger community design. But in fact, the individual buildings affect health in many ways. And some of the issues in which how a building is designed affects health. It include obesity, housing, being accessible for aging populations, the fact that there is a lot of urbanization and what kind of buildings will be built to accommodate that. Energy use is an issue in buildings, how water is used, stored, excesses as well as shortages, how buildings respond to natural disasters, climate change. All these are issues that architects can contribute to. How we build stairs in buildings and how accessible they are affects physical activity within the building. And this building here, there's a stairway you walk in, you can walk up the stairs. A stairway can actually beckon and encourage your use. On the other hand, and this picture was taken this week in Canberra, we can get a fire door with a set of warnings. There's a stairway behind that door with warnings of keep closed, do not open, do not obstruct. And in fine print, people who interfere with the operation of this door are guilty of an offense under the Fire Brigade Act. Well, if you design... Yeah, there are whole issues of what is locked. That is an appropriate issue, and security is an issue. You can build buildings when you are concerned about security, that people who have passes to the building can have passes to the stairs. But those choices that we make between ones that clearly say go away and ones that say come use me do make a difference in people's behavior and in the physical activity they will get. I want to spend a few minutes on health impact assessment. This is a tool that we've been using in the States. We adopted it from Europe, and you are using it here in Australia and New Zealand. And I'll be meeting with some of our UNSW colleagues in a week or so about some of the projects with health impact assessment. What we learned early in public health was that while health can be concerned about the built environment, if you want people to walk, you have to give them a place to walk. Public health does not build sidewalks and bike paths. Public health does not build the built environment. The people who do are the planners and architects, developers, city councils, zoning commissions, and others. And we needed a way to build that communication between the public health officials who understand these issues and those in these other sectors who actually make those decisions but may have very little input, typically from the public health world. And the tool that rose to the top, called Health Impact Assessment, is looking at the health issues in proposed projects and policies and conveying that to those decision makers. The formal definition is a systematic process using various data sources and methods, considering input from stakeholders to determine the potential effects of a proposed policy, project, plan, or program on the health of a population, the distribution of those effects on the population, and then making recommendations on how that proposal could be improved to make it more health promoting. The vision is that ideally planners and other decision makers would want that health information as part of the decisions they're making, and this would be a tool that health officials could use to facilitate conveying that information and leading to better decisions. The steps involved in health impact assessment: screening to decide where it's useful, scoping what health impacts to include, assessment, who's affected and how, recommendations, how can we improve that proposal, reporting, getting the information back to the decision makers, and then evaluation and monitoring of what difference did it make. Issues come up immediately: should it be voluntary and convey the information readily, or regulatory? It'll get used more if it's regulatory, but much more cumbersome and litigious and complex. Voluntary may not be used as much, but is a whole lot easier to do if it is used. Complexity becomes an issue. What should be qualitative and what should be quantitative? Qualitative is a lot easier. Build a sidewalk, more people will use it. But quantitative is how many more people will use it. I need some numbers. I want to do a cost-benefit analysis. And it becomes very difficult to get those numbers in many settings. For some things, we do have numbers. We have numbers for the US looking at public transit. Most public transit trips begin and or end with walking, and we were able to use large national transportation data sets to be able to say that the median number of minutes walking to and from transit is 19 minutes. So that's 19 minutes of activity. And about a quarter of all transit users get at least 30 minutes of activity just walking to and from transit, which is meeting our Surgeon General's recommendation for physical activity. So we're able to put some numbers on public transit's good for health. And that, we hope, becomes an argument as you make decisions such as light rail in this city and other public transit decisions being made in other places. HIA's health impact assessments also can and do usually include community involvement. It helps with buy-in, it helps identify issues that may not otherwise be recognized, routinely used in the environmental impact process in most places, but it can add time and resources, so not all HIAs do end up having community involvement. We have some studies showing impacts of HIAs on subsequent decisions. In some cases, we can show that it improved the plan or got some noise mitigation measures adopted and so forth. In most cases, it at least raises awareness of health issues, even when we can't always show the cause and effect of how it improved health. In the US, where we've done several hundred HIAs, Europe is probably in the thousands. They've been used fairly widely across the country. The types of projects and policies for which they've been used include housing redevelopment, transit lines, after-school programs, living wage ordinances, power plants, oil and gas leasing policies in Alaska, quite a range of policies and projects for which HIAs have shown to be useful. And one example, relatively recently in Los Angeles, they wanted to tear down some low-income housing, displace people, and build an expensive football stadium. Obviously, that's not good for the health of the low-income disadvantaged population who are being removed. And typically, they don't have a very loud voice when a project like this comes along. In this case, the advocacy groups are able to work with a group to do a health impact assessment to show those adverse health outcomes of displacing poor people to build this fancy stadium. And they were able to get into negotiations. And part of it was by being vocal. Those advocacy groups showed we can tie up your project for a pretty long time if you don't negotiate with us. And that process ended with negotiations that yielded a reasonable amount of money going toward affordable housing, toward parks and open space, and toward some benefit for the people who were being displaced, who without the HIA and without the negotiations would have had nothing but harm coming from that stadium. I want to spend a few minutes on sustainability and health. The two are related, and the term that we often use is co-benefits. The definitions commonly used: health, as mentioned, state of complete physical, mental, and social well-being, not merely absence of disease or infirmity. For sustainability, the definition we often use is meeting the needs of the present without compromising the ability of future generations to meet their own needs. There's a number of things we do that clearly overlap between health and sustainability. So if we build and use walking and biking infrastructure, if we take the stairs, if we plant trees, if we buy locally grown food, a number of things are very much in favor of sustainability and health. Some things are good for health and don't really impact sustainability much. If I take the stairs personally, it's not having a big impact on sustainability. If I get regular exercise or get enough sleep. And there are some things that are good for sustainability. If I recycle newspapers, have kind of a marginal effect on health. But for the most part, many and most things we do that are green and sustainable also are health promoting. Some of the areas looking at this overlap between health and sustainability. How we build our buildings, green buildings, energy efficiency, daylighting. Well, there's climate benefits, there's environmental benefits, lower carbon footprint down, decreased air pollution, and then health benefits of cleaner air, more comfort, natural lighting, decreased toxic exposures. Transportation, really the ones we've already talked about. If you have more active transport and transit, you get more physical activity, cleaner air, and climate benefits and environmental benefits that we've mentioned. Overall, urban design, that's really what we've been talking about. Compact, mixed-use neighborhoods, very favorable toward climate change, very favorable for health benefits. Saving nature, restoring our ecosystems, accessible parks and green space. Again, good for health, good for physical activity, good for social capital, but carbon sequestration, habitat resiliency, a number of climate and environmental benefits. So a lot of overlap on these. Energy use, again, the same kinds of things as we switch to renewable energies. Health benefits of reduced cardiovascular and respiratory disease, and certainly benefits of reduced carbon dioxide emissions. Food and agriculture, as we do more local production, eating lower on the food chain, organic farming, climate-tolerant crops, health benefits from healthier eating, and climate benefits from reduced deforestation, reduced fuel and transportation costs. Preparedness, as we work on resilient communities and building the public health infrastructure so that we can respond when disasters happen. It has climate benefits as there's increased public awareness, increased ability to recover from disasters, and decreased morbidity and mortality when those disasters do occur. I want to just mention a range of policies and tools that, some of which I have mentioned, some of which we can go into more in the discussion, that help promote healthy communities. The first few on here I've mentioned: complete streets, bike sharing, safe routes to school. Some of these others, a benchmarking report looking at what happens in different communities. We've done a benchmarking report across the U.S. showing what happens across 50 states and the 50 largest cities, comparing how they're doing on walking and biking. And what that does is the states and cities start to become a bit competitive. Oh, our neighboring state or our neighboring city has better numbers than we do for how much walking, biking, how much infrastructure, how much money is being spent on it, how many police are on bicycles, does transit allow bikes on buses, and those sorts of things. And we've had some very good evaluations showing that providing that information across different jurisdictions starts to get those areas a bit competitive, and legislators and decision makers say, we can do better. We want to be ahead of our neighbor who has better numbers than we do. Safe routes to schools can be expanded to, why not, safe routes to all your major destinations, parks and transit and other areas. Transport funding, major issue. How do we have a finite amount of transport dollars, but how much of it should be roads, how much of it should be walking, biking, infrastructure, and transit and other areas? That's a political decision, but can make a big difference as we decide what that balance should be. In our country, we have a lot of abandoned rails. You may not have many here, which we're turning into biking and walking paths. Very well used when we do that rail-to-trail conversion of abandoned rail areas. Unbundling parking. Why should every house and apartment come with a parking space? If we make them separate economic decisions, you can buy that house or apartment separately and then decide, do you want to spend that extra money on the parking? Am I okay? Okay, good. And multimodal level of service is it's a technical term from the transportation world, where most roads are built from the idea that we want to move more cars faster. Multimodal says, why shouldn't roads be looked at for how do we move cars and bikes and pedestrians and transit? And if you use that as your metric, you get better transportation. Okay, I just want to, I thought I had, I'm sorry, yeah, one more in here just briefly. We mentioned school siting, LEAD and D, Walkscore, health impact assessments, a few other areas. There's some active design guidelines came out of New York City for healthier buildings and the areas around them. issues of schools sharing some of their green space with the community to give people places to be physically active, putting a health component into comprehensive and regional plans, having a urban growth boundary to help decide where you want to be building. We have some failed suburban shopping malls. Some of those are being retrofitted and revitalized as mixed-use communities. And finally, having joint degrees so that we get public health people learning something about planning and planning people learning something about public health. Just want to mention we have a book that some of you may have seen that covers a lot of these issues. And end with 2 websites. One is our CDC website, cdc.gov Healthy Places, that covers a lot of these issues, and also the healthimpactproject.org website that has a lot of information on health impact assessments. So with that, we'd like to close and looking forward to the discussion. Thank you.